good afternoon, and I've got to thank Srinivas for putting up this absolutely amazing meeting. In fact, he was in Malaysia just 1 month ago, and where we had a very integrative meeting on airway. I'm going to run through a 45-minute presentation in 13 minutes because there's just that much of information, and it's going to be a bit different because for me, the idea of treating OSA is a little bit different, and what I focus on is talking about integrative approach or interdisciplinary approach. And these are the usual disclaimers. Why are we here today? We still are learning, and I think this is one area that we have seen a huge paradigm shift since the time I've started treating patients in sleep apnea. And one question, when the patients sit in front of me, I ask these three important questions. Is there any physiological function more important than breathing? Think about it. Does it matter how we breathe? And if you look at OSA, OSA basically is a breathing dysfunction. And here, what I mean to get this message across is, we need to understand what was meant to be normal before we address what is abnormal. Or if you understand what is actually going on in the body, it is rightfully what the body has learned to adapt to. So if you ask yourself this question, and I talked to Srinivas about this, I said, if you are really focusing on treating OSA, you have missed the boat. Because for me, treating OSA is treating terminal stage cancer. You have missed the whole opportunity of getting this problem corrected before it ended up in this. And now we are talking about treating different phenotypes, endotypes. Rahul did a brilliant job on that. But it's like an oncologist who's trying to treat cancer. And we are still seeing our success and failures. So what are we really treating? Are we treating a sleep breathing disorder? Is it purely a breathing dysfunction when we are sleeping? Is it an awake breathing disorder? Is it purely a breathing dysfunction? Hence brings forth this question, what are our aims and objectives for treatment? Is it just correcting OSA or returning the body to its functional rehabilitation? That means to restore physiology. My viewpoints, are we oversimplifying a very complex problem? Breathing is a vital function, and I'll talk about this more. And the body will adapt to make sure that we always take our next breath, and that comes where the problem comes. So we talk about form follows function, very common thing that we talk in dentistry, but I feel it is actually a interrelationship. Form follows function and function follows form. And function is important to prevent relapse of whatever that we are doing. And if you look at the whole picture today, can anybody tell me one objective test that we can do to get whether the patient is breathing correctly or not? I'm not going to go into the how we breathe because that takes a lot of time. But if you ask me, a sleep study is actually a very indirect measure of breathing. And what we deem as success. Is it measurable against, are we just correcting the parameters that we think is normal? Or are we, when we call ourselves success, are we really restoring physiological function? So if you look at this chart, it starts young, and the key component here is nasopharyngeal obstruction. And if you look at OSA, OSA is only one small component in that whole picture. Right? So that's why I said we missed the boat. So it's a complex condition, it's multifactorial, it starts young, progresses in severity without intervention. But at least us in ENT, we are still too luminal in our approach. Our solutions are more of a band-aid rather than curative with sustainable outcomes. And this includes all our current modalities of treatment. We have seen all this over decades. We've talked about calcoplasties, we've talked about adenoids and tonsils in children. So we really need to understand what are the short-term outcomes versus long-term functional and physiological rehabilitations. Any form of space-creating procedure will bring about improvements. That is very clear. That's what we are deeming as success today. But sustainability and long-term outcomes will be the key. So I always, when I talk about breathing dysfunction, right, I always show this diagram where it's a very interplay between structure, function, and adaptation. So this is a very recent study where a lot of airway dentist people were up in arms when they said there was no difference between rapid maxillary expansion and postural waiting in pediatric OSA. Now, take this with a pinch of salt, and I'm not going to go into the details of this, but what I want you to understand is today all the things that we're doing in terms of growth modification and myofunctional therapy, we have to understand that the evidence is low grade, supporting their efficacy. And that is why everything that we do now is questionable. But I think the correct way to move forward, as Rahul has put it nicely, is we need to find it's a very tailor-made treatment for every different patient, because every different patient has got different subtleties in their adaptation. So moving forward, in the integrated team approach that I have in KL, that is our team. And it is not a one-man show. In the dental group itself, we have a myofunctional dentist, we've got an orthodontist, a max-fac surgeon, pediatric dentist, and in the medical, I basically, myself, and I get a few referrals from the peds and the physicians, and another very important group, which I forgot, is the psychiatrists, and I'll come to that later. But this group of people, the osteopaths, the craniosacral therapists, the myofunctional therapists, and the lactation specialists, they are like the physiotherapists to the orthopedic surgeon. These people are going to be our supportive treatment for the work that we do. So I'm going to talk a little bit about body workers. Why osteopathy? Now, osteopathy is a very interesting science that looks at the body as a whole functional unit. It was described by Dr. Steele in the mid-1800s. Now, interestingly, he was a physician, engineer, and minister. Okay? Now, it's nice to know that in OSA, when you talk about OSA, we are talking about structure and function. And if you go on to breathing, I'll talk about the spiritual part of it later. And the first school that he opened was in 1892, and more than 50% of his students were women. And this will allude to my next lecture, which I'm going to talk about women in sleep disordered breathing. So the tenets in osteopathy, basically the three main tenets. The body is a single functional unit. There's a reciprocal relationship between form and function, and the body possesses a unique ability to heal by itself, self-regulation and healing. So we forget one important term from physiology, which is homeostasis. So the body will do whatever it needs to do to maintain homeostasis, and breathing is that function. It will do whatever to do to get that homeostasis of that body. Now, in osteopathy itself, there's a subdivision called cranial osteopathy, which was described by William Garner Sutherland. What he actually says is, the 22 cranial bones have inherent motion, which is very interesting. And this is measured by palpation, very subtle palpation, where they look at this PRM, it's called primary respiratory mechanism, and also CRI, cranial rhythmic impulse. And this connection through the dural membranes to the spine, to the sacrum, they feel something called this reciprocal tension membrane. And this is a dural attachment. And osteopaths treat these intracranial sutures through gentle palpation, listening, and following the PRM. Okay? So, when they feel the skull, the basic occiput and the sphenoid, and all the single bones are anterior-posterior movements, the paired bones are lateral movements. So they see all these kind of different bending and different rotations, and they know how to release these tensions. And in craniosacral therapists, they look at that RTM. So to understand this, if you look at, we always thought that there was no motion, right? When they did face-based MRI, they amplified the movement of the brain. Can you see how much of movement there is in that brain? And this will allude to things like gene lymphatic circulation and CSF and all these things, and that's a different lecture by itself. So to understand this, these are some books that you can read. And we know now that we are inherent neighbors with the dentist, and there have been good articles talking about cranial stains and malocclusions. See, in all of the talks that I give, I basically tell them there are two simple equations that you follow. If you have a skeletal malocclusion, it means you're nasally obstructed. If you have bad posture, you are a dysfunctional breather. So, also now they are getting more and more literature coming out on osteopathic manipulation and fascia and its connections. And this is very, very important, because we now know that the facial connections actually have got something to do with posture. And the tongue actually connects all the way down to the close to the deep facial line. So just, if you run through this quick video. So if your facial connection is very free, you've got free movements of all your whole body. But if you sort of have a facial restriction, see what happens to your movements. So you can see restriction on the side of the tightness, and also the other side is also now restricted. In view of time, I'm just going to run. So this now explains with the deep facial connections that the tongue position can actually cause postural changes. And by occlusion, if you now look at this, these are all studies that are showing dental occlusions and the various postures. This may actually relate to tongue position in the oral cavity. So something to think about. And again, some very interesting literature here. Myofunctional therapy is something that we cannot run away from. I think it's going to be part and parcel of our treatment. The two main bodies today that talk about myofunctional or rather accredited myofunctional training is the IAUM and the AOMT. Whose domain it is, the accreditation, the credentialing, all these things are things that we have to see what's going to happen, but there's enough literature out there to support its work. And these are a lot of books that I would actually encourage you all to read if you want to understand more about this whole holistic area. Now, dental sleep medicine, the team players are basically an airway-focused primary care dentist, pediatric dentist, orthodontist, maxillofacial surgeon, and a periodontist. And David Tay, who was there in Penang, put up a nice word and he said, maybe every dentist should look at airway, and he said, maybe we should call ourselves prana dentists. I don't have to tell you what prana means here. Audrey just gave a very good talk on this, I'm not going to go. But in the medical fraternity, what we really need to understand is we are still working in individual silos. Moving forward, we have to define our roles in this integrated team, and integration and working together will be key. And it should move towards patient-centric treatment and not doctor-centered approach. So just to briefly show you what we do, all of us see cases and we inter-refer to each other, and we work in 4 stages. So we have a pre-application stage or a pre-rehab stage, then we move into the structural correction phase, and then we move into the rehabilitation phase, and then into the habituation phase. So in each and every aspect, all of us have got our roles defined. So it's not you do, I do, it's we do, and we're working on the patient as a single unit. Then we have the structural correction phase where, depending on what needs to be done for these individual patients, and then we follow up with rehabilitation and the adaptation. And I want to show you about adaptation, why myofunctional therapy is important is maintaining ideal orofacial and pharyngeal postures and movements that support the most open position of the airway have to be looked at until we achieve. This has to become the new habit. I'm not going to run through this case example in view of time, but my take for now, structural correction is only a tool to facilitate functional rehabilitation. Identifying the underlying cause is paramount and pivotal in the treatment. Surgery can be more conservative to preserve as much possible normal structure and prevention of scarring, and there is no fixed or standard protocol. Every patient is an individual case. Integrative care is the future. Interdisciplinary care, team approach, I think there's a lot of unlearning and relearning. Definitely more research is needed. Maybe the future will look something like this. Antenatal health and risk stratification, I'll talk about that later, the next talk. Genetics and its influence on structure. We look at delivery process and then all the parafunctional habits like feeding habits, allergies, environmental influences and diet. And we will know from childhood itself whether it's a primary structural deficiency leading on to a secondary oral myofascial dysfunction, primary oral myofascial dysfunction leading to secondary structural dysfunction. At the end of the day, it's a breathing dysfunction that is going to lead on to an end-stage problem like OSA. Why I've taken down this different path is because if you will realize I myself am a patient, I've gone through all of this to understand the different aspects of the journey that I've taken. To finish up, I just wanted to show you this around this video. Basically, our human body is like planting a seed that grows into a tree. So there are influences and there are effects. So if you look at it, when you plant a seed, that means in pregnancy itself, look at the influences, the mother's breathing, mother's stress, sleep problems, abnormal positions, twin pregnancies, genetic influences, and how this can affect. And then birth process, what are the effects? Childhood, feeding, lifestyle, diet, what they can lead to. And in adolescence, we are looking at diet and lifestyle and environmental issues leading to all those effects. And then in adolescence and in elderly, and if you want to age healthily, this is what we need to do. If not, we're going to see a lot of problems. And my last slide, I cannot leave a place like India. I think in the whole of health, if you look at, there's nothing more important, and that's why we refer it to the breath of life. We don't call it the heartbeat of life. And that summarizes one word, pranayama. It means vital life force, and yama means to gain control. So I think we have that power in our hands today to change health of our nations. Thank you.
Thank you, Jeevanan. As always, very, very wonderfully summarized to give the entire gamut of OSA.